You may increase the overall gain to the entire screen by turning the gain dial clockwise. Likewise, you may turn the gain down by turning the gain dial counterclockwise. There's also an easy button that automatically adjusts gain. When you press this, it pauses for a split second, then chooses the best gain setting. Depth is an important consideration for any scan. You adjust this by pressing on the depth button on the console. Pressing up on the depth button decreases the depth, making the image more shallow. Pressing down on the depth button increases the depth, making the image deeper. The goal is to avoid having unused imaging space in the far field, so use your depth.
The parasternal long axis view. Begin by placing the probe at the second intercostal space at the left sternal border. The dot will be pointing in the direction of the patient's right shoulder. Scan down the left sternal border until the image comes into view. You may need to tilt or rock your probe to obtain the best image. Note the chambers are labeled for each structure.
So now let's take a look at the images that we'll obtain by performing the parasternal long axis view of the heart. Here's a nice pictorial to the left, and what we see is that the most superficial structure will be the right ventricle. Notice that the right atrium is not seen from this plane. Directly posterior to the right ventricle will be the left ventricle, and to the right of the left ventricle will be seen the left atrium. We can also see the mitral valve in between the left atrium and the left ventricle, and a little bit of the aorta above the left atrium. Let's look at the ultrasound still image here to the right, and again we see the superficial right ventricle. Posterior, we see the left ventricle with its more muscular and hypertrophic walls. Notice the left atrium is seen to the right of the left ventricle and the mitral valve in between the two chambers. We categorize this as left ventricular inflow tract. Note the aortic valve sitting right above the left atrium, and we see a little bit of the aortic root there. This is what we categorize as aortic outflow tract. Let's now take a look at the parasternal long axis view of the heart in action. Remember again that the most superficial chamber will be the right ventricle, and the normal dimensions of the right ventricle are that it should be about half the size of the left ventricle. If the right ventricle is the same size of the left ventricle, that could be a sign of RV strain. We see the left ventricle posterior to the right ventricle. Note its hypertrophic walls. This patient actually had long-standing hypertension. Let's look at the percentage change from diastole through systole, and here we see that the walls come in well with each heartbeat, indicating good contractility. We see the left atrium to the right of the left ventricle, and notice the mitral valve flipping up and down in between the left atrium and the left ventricle. We see here good movement of the mitral valve, indicating a good amount of blood flowing between the left atrium and the left ventricle. Now just above the left atrium and to the right of the left ventricle, we see the aortic valve. And notice there, just to the right of the aortic valve, a little bit of the diamond-shaped aortic root. This will be our left ventricular outflow tract. Now another very important structure to identify on bedside sonography is the descending aorta, which is a cylinder cut in cross-section right below the mitral valve as seen in this image. This is a very important landmark because the posterior pericardial reflection, that white line seen posterior to the left ventricle, comes off anterior to the descending aorta. This allows us to tell if the fluid that we see there may be pericardial or pleural.
Parasternal short axis view. Moving from the long axis positioning, you will now rotate your probe clockwise until the dot is directed towards the patient's left shoulder. Tilt and rock your probe to obtain the best view. Note we are visualizing the papillary muscle view of the left ventricle. The chambers are also labeled for each structure.
So as for the IVC examination, why do we do this? Well, it provides a good look at the IVC and the patient's volume status in a non-invasive way. What are we looking for? We're looking for collapsibility of the IVC. It's natural with the patient taking In inspiratory breath, the IVC will decrease in size. We're looking at the degree to which the IVC decreases in size, and that's the collapsibility index. My recommendation is to take a look at the IVC in longitudinal or long axis just after it enters the RA. You can use the transverse view or short axis view as well, and the measurements are typically 2 to 3 centimeters distal to the IVC RA junction. So for collapsibility index, we expect to see a nice plump IVC that with inspiration will decrease in size. To calculate the collapsibility index, you're going to take the maximal diameter of the IVC minus the minimal diameter over the maximal. That'll give you a percent collapsibility. Now, where are we measuring from? We're measuring approximately 2 to 3 centimeters distal to the RA IVC junction. The site at which I tend to measure is indicated by the double arrows. Now, there is a pitfall to this. As I mentioned, when you turn the probe up towards the patient's head, your tendency is to slip just slightly towards the patient's left, which will put you directly over the aorta. Now, the aorta is a rather thick-walled vessel, very echogenic. It's pulsatile, but the IVC is also pulsatile, but the aorta also has branches, the celiac trunk, the SMA, etc. You just have to be very careful of which vessel you're looking at. So we're going to start off looking at the patient's aorta and then moving over to the IVC, a very thin-walled structure that does not have branches. Again, let's move back over to the patient's aorta, very pulsatile, to the IVC, also pulsatile, just a little bit different. And you can see with inspiration that the walls are collapsing slightly. Now apply this to the hypovolemic patient. In the B-mode ultrasound on the left side of the screen, we can see collapsibility of the patient's IVC with inspiration. It's nearly complete collapsibility. We look on the right side of the screen, the M mode, and we can see that with inspiration, those two walls nearly touch one another. So this would be a patient who's quite hypovolemic with a very collapsible, essentially 100% collapse of the IVC. In this B-mode ultrasound, we see the same type of finding. With tidal inspiration, we see nearly complete collapsibility of the IVC, RA-IVC junction, and then we're measuring right about there. In this case, we barely even see an IVC, which of course collapses with inspiration. Down here, a very, very small IVC, very small diameter that with inspiration collapses. Now, the hypervolemic patient will have a very large plethoric IVC that has very little change with tidal inspiration. On the M mode on this side of the screen, you can see that the IVC is over 2 centimeters, probably over 25 millimeters in diameter, and it has very little change with tidal inspiration. This chart was developed from research by a group of cardiologists. They were trying to associate IVC size and collapsibility with respiratory change and associate that with RA pressures, so a non-invasive estimation of the patient's volume status. They found that with very small IVC sizes and collapsibility that the RA pressure was quite low. With very big IVC sizes and no change with respiration, the RA pressure was quite high. I will say with my own research, the extremes are what are helpful. So if an IVC is extremely small, there's 100% collapse, the RA pressure is less than 5. If the IVC size is greater than 25 millimeters and there's no change with inspiration, then the RA pressure is over 20. This can inform your diagnosis and management of your sick hypotensive patients. So let's put this all together. If we have a hyperdynamic heart on echo and a flat IVC, we're already thinking about early sepsis or hypovolemic shock. If the patient is hyperdynamic and has a big IVC with little collapsibility, you need to start thinking about pulmonary embolism or tamponade. If the patient has reduced ejection fraction and a big IVC, well, clearly they have cardiogenic shock or even late sepsis.